Good evening, welcome, and thank you for attending our Head of Cancer lecture series this evening, sponsored by the Allegheny Health Network Cancer Institute. My name is Margie Leslie, and I'm the Director of Nursing for the Cancer Institute. There are a few housekeeping items that we want to review before we start. During the presentation, all participants can type questions into the chat or Q&A portion of the Zoom. We will be addressing those questions at the end of the lecture if time allows. Participants are not able to speak during the conference, but again, we encourage your feedback via the chat option. Tonight, we're excited to welcome Kyla Morphy, who is a master's prepared genetic counselor, and Tiffany Koss, who is a doctorally prepared nurse practitioner, to talk with you this evening regarding our topic of the cancer risks hidden in your genes. Ms. Morphy is a seasoned genetic counselor with nearly 2 decades of experience. Her career spans roles at LabCorp, University of Maryland, where she helped establish a pediatric and adult cardiovascular genetics clinic, and at Allegheny Health Network, where she currently manages and is expanding oncology genetic counseling services across more than 10 locations. Dr. Koss brings over 10 years of experience in medical oncology and hematology in her current role, overseeing the AHN cancer screening program at Allegheny Health Network Cancer Institute. She joined the Institute in 2013 and is committed to improving early detection and access to vital cancer prevention services. She earned her bachelor's degree from Indiana University of Pennsylvania and her doctorate of nursing practice from Robert Morris University. It's my pleasure to welcome Kyla and Tiffany, and I'll turn it over to Kyla to begin the presentations. Welcome, ladies.
Thanks, Margie. So I'm going to start us off today. I'm going to go through an overview of genetics of cancer to start, and then review some of the features that may be suggestive of an inherited cancer gene in the family, and go over some high-level information about some of the more common hereditary genetic conditions that we know of. So I always like to start off with just a quick little overview of cancer risk in general, because I feel like it's a good way to see that there are multiple different factors that are at play in developing cancer. And so you can see that it is not one thing that we can ever really pinpoint that we know causes cancer, but multiple things that kind of interact together. And some of these things are things that we can control a little bit more, like maybe lifestyle and some of our environment. There are some things that we can't really control at all, like aging. Unfortunately, we do all get older. And then that chance occurrence. And then the other parts that we're going to focus more on today, which is that, family history and genetics, which is another part that we don't have much control over, but we do have control over what information we find out and what we can do with that information. So, like I was just mentioning, there never is one thing that we can say, pinpoints cancer risk. But we do know that there's all these different factors that come into play. And when we talk about hereditary cancer in general, those genetic factors play a larger role in the cancer risk. Again, it's not the be-all, end-all answer. It's just a piece of the puzzle. But when we're talking about these, hereditary or inherited cancers, we know that those genetic components may be, increasing the risk over that general population risk. But then there are those other factors that also are at play in determining whether or not someone develops cancer. When we talk about these, genetic causes for cancer, we really are focusing on a small portion of cancer in general. I always say it's small but important. So these hereditary or genetic causes for cancer make up about 5 to 10% of all cancer diagnoses. There are some cancer types that do have a stronger genetic component, like ovarian cancer, but the general number that we typically look at is about that 5 to 10%. A majority cancer falls into that green sporadic area. That's that 60% of cancers that really do just happen by chance. That there aren't any other factors that we really know of at play. It's just that chance occurrence that cell, became a cancer cell. And then that, in between red area is what we call familial. That's probably the hardest part to really conceptualize. But that's a combination of maybe some small genetic factors and then other things that we share with our family as well, like where we grow up in that environment and those other, lifestyle factors that we also tend to share with our family members. of that, 10% that actually has some, underlying genetic factor, there are different tiers of risk even within that genetic component. We know some genes, and these are ones that people may have heard about or be familiar with, that have a higher rate of cancer if someone has one of these genetic markers. And those are things like BRCA1, BRCA2, which are associated with like breast and ovarian and pancreatic and prostate cancer, or Lynch syndrome, which is a hereditary like colon cancer syndrome, but also we can see like uterine, ovarian, stomach, pancreatic cancer with that. These genes are ones that have about up to an 80% risk for some types of cancers. So a lot of people that have these, higher risk genes are ones that we do see those family histories even that are a little bit more suggestive of something genetic, where we're seeing, cancer in multiple generations. The other, tiers of genes that we know of are some of these newer genes that we've discovered and started testing for just about over the last 10 years. It was about 2014 that we started doing testing for some of these, additional genes. And a lot of these genes have a much lower overall cancer risk. So if we're calling something a moderate risk gene, we're usually saying that the highest end of the cancer risk with those genes is 50% or less. So that's important when we're thinking about what we're looking for in family histories, because we may not always see that pattern if someone still has a 50% chance of not developing cancer. And then, like everything else in medicine, we are always learning more. Right now, even with some of the more, well-known cancers and genetic causes, we still know that we're missing some genetic markers that we haven't quite discovered yet. So there are, even newer genes that we are sort of in that preliminary phase still, and a lot of them likely do have lower cancer risk. That's probably why we're taking longer to discover them. But one of those things that, again, we always have to kind of keep in the back of our mind. If we're not seeing a pattern that we typically think of, maybe it's because it's, one of these lower risk genes. So, how do we assess for hereditary cancers? Who are the individuals that we really want to, make sure that we do at least consider this possibility for? So I always tell people, some good rule of thumbs is that we think about things that are a little bit more unusual. So if we think about, younger onset cancers, typically, for breast and colon cancer, which are more common cancers in general, we're not necessarily thinking about everybody that's had breast cancer or everybody that has had colon cancer, because a lot of the times it is going to be that sporadic or that chance occurrence. But if it's someone that's diagnosed before the age of 50, that's kind of our cutoff to say, hey, this is a little younger than I expect to see by chance. Maybe there's some genetic marker here. We also, want to think about those rare cancers. So kind of going back to the unusual, any rare cancers are ones that we do think about a higher, likelihood of maybe being a genetic marker. And those are things like ovarian cancer, male breast cancer, pancreatic cancer, a very specific type of stomach or gastric cancer called diffuse gastric cancer. And then some things that people may not have heard of frequently, but like pheochromocytomas or paragangliomas. All of those are a little bit rarer and do have a higher chance of being genetic than that, like 5 to 10%. The other thing that we're looking at is that family history. But remember, we have to kind of think that sometimes we're not going to always see that family history now that we're learning more about some of these newer genes. But we're looking for, 2 or more people, 2 or more cancers in one person, or multiple people in the family with the same type of cancer or related cancers. And the related cancers is where I always tell people I feel like a bit of an investigator to go, okay, I'm looking at the pattern in your family, and then trying to figure out, if that pattern is something that could be explained by a single gene that we know about right now. So just some of the ones that we think about sometimes are things like, if we see breast and ovarian in the same family, or, breast, thyroid, and uterine, or breast, sarcoma, and brain. All of those different combinations might point us in different directions in terms of a possible genetic marker. And then same thing with the family, even if the person we're looking at maybe has a cancer diagnosis over the age of 50, if they have a family member who's diagnosed, on that younger side, it's another one of those things where we just go, hey, maybe there's something going on here. I always, like to note, because we do know, there's people who don't have family history information for multiple reasons. Either they're adopted or, they have families that just didn't talk about these things. And so I always, like to remind people again that we deal with what we have. We know, sometimes we know that we don't know everything, and we rather be, more inclusive in looking at that family history than go, oh, great, there's probably nothing there just because we don't know about it. Just because we don't know doesn't mean it's not there. Most of these hereditary cancer conditions that we talk about are inherited in an autosomal dominant way. Really, the big takeaway from that is just that we expect about 50% of every generation to have inherited that genetic marker. So if dad is a carrier of one of these hereditary cancer syndromes, each of their kids have that 50-50 chance. Looking at families as well, though, people have smaller families now. So sometimes we don't necessarily see that pattern because maybe they only had 2 kids and, maybe one of them inherited it and the other one didn't, or both of them didn't. And then we don't see that family history pattern of cancer like we, used to see. The part that is important also about this autosomal section is that autosomal means men and women inherited equally. So we care about dad's side just as much as we care about mom's side. So this is an example of a family history that I don't think it takes me to tell everybody. This looks like something hereditary is going on. So we have, multiple generations with breast cancer. We have that, younger diagnosis at the age of 34. And then we have cancers that can be linked with breast cancer. Like I mentioned, like, that breast and ovary linkage. Prostate also can be linked with breast cancer with some of these different genetic markers. So this is a family that even by looking at it, we know that there is probably something going on here. At that point, our next step is to try to figure out, can we find what the genetic marker is in this family so that we can kind of pinpoint things better for the family in terms of, other cancer risks or screening options for them. So who is a good candidate for cancer genetic counseling and testing? So, obviously it's those rarer cancers. So just looking at them, looking at any of those rarer cancers, even if there is no family history of cancer, these cancers by themselves are enough to consider genetic testing just because they are rarer and do have a little higher likelihood of being genetic than that sort of typical 5 to 10% that we think of. And they're the ones that most of these I just mentioned a minute ago, the ovarian cancer, metastatic prostate cancer. So if there is prostate cancer that has moved to different locations, there was a study that found a higher incidence of genetic markers in that specific population of patients with prostate cancer. Again, anybody with pancreatic cancer, male breast cancer, and then some of those rarer cancers like the PHEOs, the paragangliomas, medullary type thyroid cancer. So again, like rarer type of thyroid cancer and adrenal cancers. And then if it is a cancer that's more common, like breast and colon, uterine and kidney, then we are really looking more so at that younger age of onset. So if they were sort of before the age of 50, that's when we start to think about, considering genetic testing, or there might be a hereditary cause for that cancer. And then, same thing, if we do see a family history of multiple people with especially the same type of cancer, that should be one of those, triggers just to kind of say, hey, why is this happening? Can we find some answer here? Some of the cancers that typically, aren't hereditary are the ones that we know more of those, environmental or non-genetic risk factors for. Like lung cancer, mesothelioma, esophageal, cervical, head and neck, anal, skin cancer, bladder and kidney. A lot of those we do have, environmental exposures that we know can increase those risks and are probably more of a risk factor than, something hereditary. Not that there can't be hereditary factors in there, they're just a little less commonly hereditary. And then some of those cancers that, do look to be more sporadic, that we don't see multiple cases in a family member, like, brain cancers, bone cancers, liver, testicular, papillary, the non-medullary thyroid cancers, so like papillary, follicular, anaplastic. And then the leukemias and lymphomas and multiple myelomas. I feel like this is a question that we get, fairly frequently, because I am sure, a lot of people do know families or have it in their family themselves, where you see, multiple individuals with those type of sort of, hematological or blood cancers. It is an area of pretty active research. So even if we don't have, really good genetic testing for that group right now, I feel like every year we are learning more, maybe discovering more genes, and it may have more options in the future. But, right now we don't have a lot of genetic testing available for those type of cancers. So if someone has, one of these features that we were just talking about, the next step is usually to come see someone like me. So come see one of the, oncology genetic counselors. And when they come in to see us, we go through the family history in a lot of detail. We go back 3 generations, so back to grandparents. If we can do great grandparents, great aunts and uncles, great. The more information, the better. But again, we can deal with whatever information we're able to obtain. And then we'll talk through, does this family look like something that could be that, 5 to 10% that actually might have a hereditary factor in their family. And if it looks like there could be, then we would talk about doing some genetic testing. And that's really the next step in all of this, is that, if we can do genetic testing and identify the actual genetic marker that that family has, it can give us a lot more information about, other cancer risks, screening recommendations, and what we should do for that family or that individual to be, more proactive or preventative. So if someone does genetic testing, we're the ones that, can coordinate that for them, and then would call the patient back to kind of go through all of that, information on what we can see with that particular gene and what we should do about it. And then get that information to, the other doctors that we need to sort of loop in order to make sure they're getting the appropriate screening and surveillance. Appointments do take a while because that's a lot of information that we go over. So usually about 45 minutes to an hour that we go through, discussing all of this and then obtaining a sample for genetic testing. I promise this is my one quick genetics overview for the day. So just a little bit of genetics background. Genetic testing is really looking at specific genes that we tell the lab that we want to look at based on what we see in someone's family history. So just to kind of go back a little bit, in every cell of our body, we have our chromosomes. We have 1 copy of every chromosome from our mom, 1 copy of every chromosome from our dad, and we have 23 pairs in total. Along those chromosomes, we have, 30,000 different genes. And a lot of the genes that we know are associated with cancer risks are actually genes that are supposed to be preventing cancer in our body. So a lot of these genes, like those, BRCA genes I mentioned, or those Lynch genes that I mentioned, they are, supposed to be fixing errors that occur in our DNA, or, suppressing tumors. So they're supposed to be stopping cancer. So when we do genetic testing, we're not looking to see if the gene's there or not, because we should all have these genes. They're good. We're looking to see if that gene is actually working or not. And the way we do that is actually by looking at that, specific DNA code. So DNA is just the alphabet of our genes. So they kind of read through the genes to see if everything is spelled correctly. If it is, we go, okay, this gene is working. It doesn't look like this is the answer for what's going on, with that person or the family. But if we do find a spelling change and that gene isn't doing its job, that's when we kind of have a target for that person and their family to go, hey, this gene isn't working. We know if this gene's not working, we can see a higher risk for, X, Y, Z cancers. Here's what we should do about it. In case people have done genetic testing in the past, I feel like I get these questions a lot, so I just like to give everyone a little update. Things have changed in the world of genetics pretty quickly. So Frequently, we get questions from people about whether or not they need to do like any kind of updated genetic testing. Say they did genetic testing back in 2001 when they were diagnosed with a breast cancer, and we're now looking at 2025. Should we be doing something again? And the answer is yes. Their original testing, their genes haven't changed because we're looking at the genes you're born with, and those don't change with time. But there are probably more genes that we could look at now than we could back then. And the way that we look at genes has changed over time. We've gotten smarter and we're able to pick up more of those spelling changes that we just didn't know how to find back, in the early 2000s. So sort of, again, our good rule of thumb is that if someone had testing, before 2015, they probably had a pretty limited test. Mainly, we were testing for BRCA1 and 2 or Lynch syndrome back then. But now we can do much bigger tests looking at, some of the newer breast cancer genes and new colon cancer genes. So it may be something that updated testing would be helpful for them. Insurance-wise, insurances are definitely more likely to cover testing now, especially if someone has any of those features that I was talking about earlier. So those are people that have that, family history or one of those rarer cancers. And there are options to do, out-of-pocket clinical testing now as well that weren't available in the past. And the other, reason to always kind of keep in contact with genetics, even if you had testing a while ago, is that, our understanding of the genes that we do know about now evolves with time. And we might have, different recommendations about, screening or other, preventative and proactive options as we learn more about these genes. Another big question we get is, about privacy and discrimination. So genetic testing is a medical test. It is part of your medical record. A lot of places do have electronic medical records now. So, it would be part of any other labs that, other providers that have access to that record could view. But there is, a law, the Genetic Information Non-Discrimination Act, we call it GINA for short, that prohibits discrimination against individuals seeking health insurance based on employment based on genetic information. It doesn't cover those like bought into insurances like life insurance and long-term care, but it does cover, the health insurance and employment. And I wanted to, Tiffany will fill in some blanks here, but I wanted to at least quickly sort of touch on some of the things that, genetic testing can do for people if we do find, if we do happen to identify one of these genetic markers. And really, it's, three big areas that can be affected if we do find, a hereditary cancer in a family. One is that we might have different surgical management options and, recurrence risk. Another is that it can tell us more about other cancer risks that maybe weren't on our radar because we didn't see them in the family history. And then it actually, for someone who is going through cancer treatment, might even be able to help them with chemotherapy selection and prognosis. So I wish I had hours and hours to tell you everything, but I'm going to kind of hit on three main areas and three of the more, common hereditary cancer syndromes that we see and how that information can impact different areas. So for surgical management and surveillance, I just wanted to go through quickly, those BRCA genes, because I feel like these are ones that people do, know a lot about and have a lot of overlap with even some of those newer genes that are related to breast cancer. So for, BRCA1 and 2, these are those higher risk genes. And for women, we know breast cancer risk can be, 40 to 85%. And there's a higher risk of a second primary breast cancer, also a risk for ovarian cancer, male breast cancer, prostate cancer, and then pancreatic cancer and melanoma. So a lot of different things that are on our radar if we identify someone with one of these, BRCA1 or 2 gene mutations. But there's also a lot of things that we've learned that we can do to bring those risks down. And some of them are more surgical interventions, like, mastectomy or having ovaries removed. And some are different, medications we can take, like, oral contraceptives or tamoxifen to reduce those risks. Like I mentioned, BRCA1 and 2 are not the only genes associated with breast cancer. They're just the only ones we knew about or tested for prior to like that 2015. But there are quite a few different genes now as well that we would evaluate someone for if they did walk in the door and have that, personal or family history of breast cancer. And depending on, where their risk falls on, the higher end of the range or one of those more moderate breast cancer genes, it could just mean, increasing screening and surveillance. So, doing mammograms earlier or doing breast MRIs and mammograms, or, considering more of that surgical option. The other thing that genetic testing can tell us about are those other cancer risks. So I wanted to touch quickly on Lynch syndrome because this is another, yes, these are the ones we've known about the longest, but they're also some of the most common ones, which is why we did discover them first. So Lynch syndrome is more that like hereditary, we think about hereditary colon and uterine cancer, but we can definitely see other, gastrointestinal cancers, ovarian, brain, and very specific kind of skin cancers. This is caused by like 5 different genes that we would test for. And for these, if someone comes in with colon cancer and that's what we see in their family history, but then we find out they have one of these Lynch mutations, you can see that the other cancer risks that are being put on the radar. And again, some of them can be a little bit more significant, especially, in this case, if we're talking about a female, they can have that, up to 60% risk for uterine cancer. Or like, up to 20% risk for ovarian cancer, where there are some things we can do to bring that risk down substantially, including, the surgical intervention options. Or we can do, extra screening for individuals as well. So, things like your pancreas, we're not going to take out, but we could screen for that if we know, someone has a Lynch gene and maybe has, a family history of pancreatic cancer. So it could target the way that we follow people if we do find, one of these genetic answers for them and for their family. The more, recent way that genetic testing has affected, treatment and screening is that it actually now could help us with chemotherapy selections and prognosis. And one of the cancer types that this has, affected the most is pancreatic cancer. As you can see, there are a lot of different genes that we know can be related to pancreatic cancer. And the cancer risks do vary pretty significantly depending on, what gene we're talking about. But if we did find out that someone had, say, like a BRCA1 and 2 mutation that's related to their pancreatic cancer, then we do have different options for them in terms of, chemotherapy that we might lean a different way or do something in addition to their, planned treatment, just based on that genetic status. So we have found, increased survival for pancreatic cancer patients with germline mutations in BRCA1 and 2 or PALB2 that have received like platinum-based chemotherapies. So they're looking at PARP inhibitors for that population as well, with germline mutations in BRCA1 and 2. And then there are, different treatments that we could do for individuals with pancreatic cancer that have like microsatellite instability or mismatch repair deficiency. Those 2 things are more related to Lynch syndrome, but like I mentioned, pancreatic cancer also can be seen with Lynch syndrome. So again, like if they find out that's the answer, they might be doing a little bit different, treatment planning than they would if they did not find that there was mismatch repair. And then I wish I could talk about everything, and definitely, I'm going to pass it along to Tiffany so she can go through a little bit more about some of those screening and surveillance options. But if anyone is ever interested in cancer genetics, then we do see patients at 8 different locations now. One of them is via telemedicine. Although, a lot of the other ones do have that option if someone is not like able to travel somewhere. And they can call our main office. There's the phone number, just in case anyone wanted to schedule an appointment for that. But I'm going to pass it over to Tiffany to follow up with some more information on screening and surveillance.
Thank you, Kyla.
Hello, everybody. My name's Tiffany, and can you bear with me one second? I'm going to share my screen. Okay, there we go. So again, my name's Tiffany. I work with the Cancer Institute, and I help oversee the AHN cancer screening program. I know we had a couple questions in the chat. We'll probably just address those mostly at the end of the presentation. And Mary, your question about what you can do to decrease your risk of developing cancer, I will touch on during this presentation. So with that in mind, just some things I'm going to go over this evening with you are some routine cancer screenings that are recommended by some national organizations, some guidelines for average risk, and then we'll touch on, kind of what Kyla was speaking on, those patients or individuals who have maybe a higher risk of developing cancer and what we can offer for them as well. So a little bit about some cancer statistics. The American Cancer Society estimates that there are going to be over 2 million new cancer diagnoses in 2024. Now that is a new all-time high. And a lot of those cancers that we are seeing on the rise, we do have some screening tools for. And some of those cancers include breast, prostate, colorectal, and cervical cancers. And just to note that cancer deaths in those people under the age of 50, we're seeing many new colon cancers. And it's actually the number one cancer-related death or cause of cancer-related deaths in men under the age of 50, and it's number 2 for women under the age of 50. So a little bit about staging of cancer and why we recommend routine cancer screenings. So why do we recommend, those people who may not have any symptoms just go and get their routine cancer screenings as recommended? Now we know that early detection of cancer is really critical for patients. If we can find cancer in its earliest stages, we can get it treated surgically, and get those patients on with their lives. Anyway, like I was saying, early detection is critical. So when we say early detection, what does that mean, or early stage? So as you can see now correctly on this screen, just some information on staging of cancer for those of you who are not familiar with that. So when we are screening for cancer, when someone is not having any symptoms, we really want to try to find that cancer when it's in this stage 0 or stage 1. That's when cancer is at its smallest form. It normally hasn't spread to other parts of the body. We can our goal is to really remove it surgically is the best option. And that's our best hope for a cure for a patient with cancer is to catch it early and just get rid of it and get the person on with their life. Now, if we find cancer in the little later stages, stage 2 and 3, it's a little more advanced. And what that means is the cancer has grown a little bit beyond that small size and maybe invaded some tissues nearby or has spread to some lymph nodes. In general, a lot of cancers are still treatable, but much less likely for a cure as we get further into the staging. Now, stage 4, or what we call metastatic disease, is we want to try to catch cancer well before it is in this stage. Stage 4 is when a cancer has become so large that it's invading other areas, close to where it started, or it has spread to other distant parts of the body. And at that point, treatments include chemotherapy, radiation, immunotherapy, and all those treatments have side effects. And And really what we're trying to do at that point is to slow that cancer down, try to stop it from growing and prolong someone's life as much as we can. So when we say we want to catch cancer early, that's what we are talking about. So some screenings that are recommended and available for cancers. We primarily follow the United States Preventative Services Task Force national guidelines for cancer screenings. And those screenings include what is listed here. So breast cancer for women, ages 40 to 74, cervical cancer, again, ages 21 to 65, prostate cancer for men, age 45 to 75, and then for both men and women, colorectal cancer screening, which now starts at age 45, and then lung cancer screening for those aged 50 to 80 with a cigarette smoking history. And we'll talk a little bit more about that in some later slides. And then some other screenings that we offer at AHN that, research has shown we can screen for some cancers that may not fall under those national guidelines include head and neck exams, for adults 18 and older with some high risk factors that we'll go over a little later as well, and skin cancer screening. Now, I know a lot of these have listed as age cap or maximum ages here, such as the breast cancer one. Now, just keeping in mind that just because you may be older than that 75 or 65 year mark does not necessarily mean we're not going to screen you for certain cancers. Normally what that means is once you get a little beyond that age, we look at your risk factors, and then it's really an individual decision between you and your healthcare provider. So just to speak on the women's cancer screenings in a little more detail, for women, we screen for breast cancer with that screening mammogram once a year. We can also offer a clinical breast exam where a provider is, performing, palpating the breast, checking for lumps of the breast or in the armpit area for women who may fall outside of this age range. We can offer pelvic exams, which may include pap smears and HPV testing. Now, I know we spoke about the age that's 65 mark for women and pap smears. And again, that does not necessarily mean we're not going to screen with a pap smear after that age. It's just we need to look at, your risk factors if you've had an abnormal pap smear in the past and things like that, and then make a decision as to whether we do that pap smear after age 65 or not. Now, whether we do recommend a pap smear at that age, after age 65, we still recommend pelvic exams for women, normally on a yearly basis. So to speak on prostate cancer a little bit, the guidelines have really changed for prostate cancer screening over the years. So as it stands currently, prostate cancer screening, there should be a conversation between the providers and men to determine if prostate cancer screening is appropriate. And in that, I mean, we talk about any risks associated with the testing, what benefits you may provide or we may provide from that testing. And, really just having that conversation before we just order testing or do an exam. And with the exam, what I mean is a digital rectal exam where a provider will take a finger into the rectum and try to feel that prostate gland for any abnormality. Or we can order some blood work looking at the prostate specific antigen level. And like I said previously, we recommend that screening or that counseling starting age 45 up to the age of 75. However, kind of what Kyla touched on, there are patients that we know that have some high risk associated with developing prostate cancer, whether it be some family history, or Black males, or if you have a genetic mutation that puts you at risk of developing certain cancers, we will start this counseling at age 40. But really the takeaway is having that conversation with your provider. Now, colorectal cancer screening, the guidelines have updated so that now we recommend a screening colonoscopy for everyone age 45, starting at age 45. And again, if you have a family history of colon cancer, especially in a family member that's younger than 50, sometimes we will start screening earlier than that 45 mark. And again, we decrease that age of screening because we're seeing more colon cancer in younger and younger adults. Now, what we recommend with colorectal cancer screening is the colonoscopy, which most people are a little hesitant to get, whether it's because of the prep or, just fear of having some anesthesia. But there are some other options, such as the stool take-home tests, such as FIT or the Cologuard. And then some other options that we don't use as commonly, but you may see it occasionally, such as flexible sigmoidoscopy or a CT colonography. So just to touch on the colonoscopy and why we recommend getting that. So with a colonoscopy, when they go in and take a look at your colon, if there are any polyps in there or anything that looks suspicious, they can remove them during that procedure. Now, it is those polyps that we know can turn into cancer over time. So essentially, we are removing the problem before it becomes a problem for you. And then also colonoscopies can identify certain inflammatory bowel conditions, which can increase someone's risk of developing colorectal cancer over time. So then those conditions can be treated. So let's talk a little bit about lung cancer screening. We normally get a lot of questions about lung cancer screening. Lung cancer is the second most common type of cancer in both men and women in the United States, and lung cancer is actually the leading cause of cancer deaths in the US. Now, just some more statistics here. The American Cancer Society estimated that in 2024, there were over 230,000 new cases of lung cancer, and 125,000 people died from lung cancer. So it's pretty significant. Now, the average age at time of diagnosis of this is around 70 years old, and cigarette smoking is the leading cause of lung cancer. It is the reason for it in about 80 to 90% of all lung cancer deaths. But there is about 20% of the lung cancer cases, though, that occur in non-smokers. So going over other risk factors such as secondhand smoke exposure, certain environmental exposures. We're in Western Pennsylvania, radon exposure can increase your risk, as well as certain industries, such as working, in certain areas or having asbestos exposure. So for lung cancer screening, what we recommend for that is a CT scan of the chest, and it's a low dose CT of the chest. And they call it that because it has a lower dose of radiation, for those of you who are not familiar. So who is eligible for that screening? Those people who we know have a higher risk of developing lung cancer, and there are certain eligibility criteria that you need to meet so that you can get that test. You have to be between the ages of 50 and 80. You have to be a current or a former cigarette smoker, and they only look at cigarette smoking for this. And you have had to have had a 20-pack year history of cigarette smoking. Now, if you've quit smoking in the past, you had to have quit within the past 15 years. Pretty simple, right? So just talking about your history with your provider and then, sorting out whether you are eligible or not. Now, just quickly, because I mentioned pack year history. Now, that doesn't mean that you had to have smoked 20 years to be eligible for this test. what that means is, yes, if you smoke 20 years at 1 pack a day, that is a 20 pack year history. But if you smoked for 10 years and smoked 2 packs of cigarettes a day, that is also a 20 pack year history. And again, if you smoked half a pack of cigarettes a day for 40 years, also a 20 pack year history. So that's how we determine your pack year history. So briefly, just some other exams that I touched on that we offer at AHN with our cancer screening program. Head and neck exams. We know patients who smoke cigarettes or use alcohol on a regular basis, or have been exposed to HPV through sexual contact. We know that increases a person's risk of developing head and neck cancers. So during that exam, what a provider will do is look around in your mouth, feel along your cheeks and your gums, feel your neck for any lymph nodes or lumps, and take a quick peek in your ears and your nose. Now, a little bit about skin cancer screening. This is probably one of our most popular screenings. So we can look for skin cancer in any adult, really. We know certain things put someone at a higher risk of developing skin cancer. Again, like Kyla mentioned, melanoma is that aggressive form of skin cancer that we can see sometimes running in families and with that BRCA gene. And then people who have more fair skin, have had sunburns in the past, numerous moles. Definitely we recommend skin screening for those individuals. Now at AHN, we have a newer technology available called the Vectra. And what that is it is a software that uses AI, which can give us a risk assessment on how likely a skin spot is to be a cancerous lesion. Now at West Penn Hospital at the Skin Cancer Center, they can use this technology and do whole body skin mapping, which is pretty cool. But we also have handheld dermatoscopes, which you can see in this picture the provider is using to look at a mole on this gentleman. And those dermatoscopes are available through our comprehensive cancer screening clinic, and then also some of the AHN primary care locations across the network. So Mary, I know you had a message in the chat about how to decrease your risk of developing cancer. So some things like Kyla had mentioned, we have no control over, genetics, family history, our age, because as we all get older, our risk or chances rather of getting cancer increases. But there are some things that you can do to decrease your risk of developing cancer. The biggest one being do not smoke. It is the best thing that you can do for your health, not just from a cancer standpoint. Cardiovascular risk goes down. So if there's a takeaway from this presentation, do not smoke. Also limiting alcohol and eating a well-balanced diet, getting those fruits and vegetables, and trying to limit processed foods and red meat as much as possible. I know that's incredibly difficult in our Western diet. It seems like everything is processed, and it's much easier to be able to get those processed foods because they're everywhere. Maintaining a healthy weight, getting regular exercise, and then of course, getting your routine health screenings, which includes your cancer screening. So I know I said do not smoke, right? So why does smoking increase someone's risk of cancer? Now, we know that there are over 7,000 chemicals in a cigarette, and at least 60 of those are known carcinogens. And carcinogens are chemicals that we know can cause cancer. So what happens in the body is as you smoke, those carcinogens or chemicals will damage the DNA in your cells. And thank you, Kyla, for your little DNA tutorial, which in turn leads to mutations in your cells, and then ultimately over time can lead to cancer. Now, smoking and nicotine also weakens the body's immune system. And we know the immune system, again, Kyla touched on this in her presentation, the immune system fights off cancer cells. As your body, or a cancer cell arises, your immune system will seek it out and destroy it. But if your immune system is weakened or decreased for any reason, your risk of developing cancer also is increased because of that. Smoking also causes a chronic irritation in the lungs. It causes an increase in mucus production and ultimately damages the lung tissue. And it's not just lung cancer that smoking can cause or is associated with. There are many other cancers that smoking can increase that can increase your risk of developing certain other cancers, including pancreatic and colon, a lot of the head and neck cancers, cervical cancer, and most certainly bladder and kidney. So a little bit about our cancer screening program at AHN. This program started in 2014, and it has really grown. So currently we offer monthly cancer screening events at various locations across our network with no out-of-pocket costs associated with those events to whoever registers to participate. Now, we also have weekly comprehensive clinics where someone would call in and schedule an office visit with me, and we could go over any cancer screenings that someone may be eligible for, go over family history, any risks associated with that person, and then perform any screenings, as appropriate. We also collaborate with many other organizations to provide cancer screenings. And then we have other special events throughout the year. For example, we had a cancer screening event at PNC Park in October, and it was really a great event. And then in 2024, we had at least 870 patients screened at our monthly events, with at least 7 confirmed cancers found. So our monthly events, just a little more information about those. So it's always on a Saturday, one Saturday each month. And like I said, various locations across our network. Anybody can call in and register for whatever screenings they are eligible for. And again, there is no out-of-pocket cost for the services completed on the day of the event. We have screenings for up to 7 types of cancers at that one location. And then we have some other resources available on site, such as we have dietitians that participate, so you can get information on healthy nutrition. We have members from our research team through the Cancer Institute, so you could be involved in research studies. And then I just want to give a shout out to all of our great AHN providers, physicians, advanced practice providers, and other staff volunteers, because without their volunteering their time on a Saturday, we could not do what we do. And then our weekly clinic, like I mentioned, I have an office at Jefferson and one at Forbes during the week, and those are more private office visits, and you can most certainly call and schedule an appointment if you desire to do so. So again, please don't hesitate to contact us with any questions. You can call to schedule an appointment, or you can go to our website to get some more information and see our calendar of events. And with that being said, I thank you for your time and look forward to any questions you may have.
Great. Thank you, ladies. It was very informative. There are a few questions, and we'll kind of work through those quickly to be so you can be respectful of folks' time. I'll move along here. Someone's asking, will the webinar be available for someone who could not attend this session? I will cover that at wrap up, and yes, you'll be sent a link and it will be available on our YouTube channel. The next question, can you comment on your utilization of genomic testing on surgical pathology specimens to help guide patient chemo care, etc.? And is there follow-up genetic testing performed post-chemotherapy? I don't know who wants to take that one. Kyla, do you want
I
to
can take
that
it.
one?
I did start typing out a response,
Oh,
and then it was getting
sorry.
a
I'm
little
sorry.
wordy. So I'm
Okay.
like, I'll just wait till the end. Um,
Okay.
so yes, genomic testing is ordered by the oncologist for a lot of different surgical samples, but it is still very specific to certain tumor types because those are the tumor types. A lot of the ones are the ones that I kind of mentioned that we actually know that the chemotherapy might change based on the genomic profiles. Um, typically there isn't a need to repeat it post chemo, although sometimes we do see a different sample being sent down the road if there is, a recurrence or a need for additional treatment, but isn't something that they typically like do after chemo just to see, what the profile looks like at that point.
Okay. Thank you. The last other question is if you have criteria, pardon me, if you have criteria for head and neck cancer screenings, how do you get an appointment or who do you contact or do you ask your oncologist for referral? So these would be folks. Go ahead. You want to take that one, Tiffany?
So
You're
you
muted.
can
Okay.
most certainly call and set up a private appointment or an office visit with myself at one of the locations, either Jefferson or Forbes. If that's not convenient for you, you can most certainly register for one of our monthly events. It's not something you need a referral for. You can just call in and schedule a visit. Does that answer the question?
I believe so, and we'll cover the number for that as well at the end. Last question. One of the attendees is asking why they don't just do routine BRCA1 and 2 screenings with health checkups.
It's a really good question, and it's actually something that I feel like we've been talking about for quite a few years now. There has been different, societies that have recommended that be something that's considered in the future. And honestly, I think that will be how things might change in the future because, like I was mentioning, it is hard sometimes now to see that pattern. And it really is information that can change things for screening and surveillance. So I suspect in the future there will be a shift in sort of how that happens. But yeah, really good question.
Great. And that takes us to time. So we're going to conclude the questions at this point. We'd like to thank you for attending our Head of Cancer Lecture Series this evening. Please continue to join us monthly for our Head of Cancer Lecture Series as we continue to focus on cancer screening, early detection, treatment, as well as survivorship. As a reminder, tonight's lecture was recorded, and if you're interested in rewatching tonight's lecture, check back on the AHN YouTube channel at www.youtube.com/Allegheny Health Network for full recordings in about a week. You'll also be able to view past lectures at that link using our After Ahead of Cancer playlist. And if you would like to schedule any appointments, you can do that by calling the Hope line at 412-578-4673 for any of your ongoing oncology care needs. And thank you both for a great presentation. Thanks all who have attended the lecture this evening and have a wonderful evening.